next speaker is Dr. Luis Igbor. He is our beloved course director of the fifth IMC, Neuro IMC sessions today. He is a really experienced interventionist from Spain. He worked at a clinical science college Spain. So today he will give a talk about his experience in vertebral basilar aneurysms complex. Please, Dr. Luis.
Okay. Thank you very much, Dr. Waralu, Waralu, and thank you, Professor Heneniemi and Professor Waklu and Professor Bean to participate and discuss for this particular type of aneurysm. I like to present some concepts. I think the Ahai Waklu, I present some key point. And my key point is different. The invertebral basilar aneurysm is different etiology of the origin of the basilar. For example, in the proprius basilar artery, no vertebral, only basilar, the dissecting aneurysm is not frequent, but when you are this, the most important is to treat it with the best endovascular device. The risk occluded of the perforated branch is high. This is the reason when I don't use the flow diverter in middle part of basilar. This is one example of the, in 2004, with this aneurysm is treated by, yes?
I'm afraid that you did not do a screen share.
You are on the image, the screen.
Oh, don't see any presentations yet, sir.
Any presentation. Okay, just a minute. Okay, okay.
I'm sorry, Warlock, I didn't even pick that up.
Yes.
Yeah. I'm listening.
Seamless production.
It's okay?
Yes, perfect.
Okay.
Yeah, perfect.
Okay. Don't worry that the first two slides don't have a problem. In the middle part of basilar trunk, I use every time the standard technique. This is treated in 2004, is jailing and stent, no flow diverter, open cell stent. Why? Because this is the reason you don't have the thrombus of the perforant vessel. This is the control, and this is 1 year control. You are total occluded and endothelization of the neck with the neuroform or atlas stent. At this period is neuroform. But sometime in the dissecting aneurysm on this region, this is an example. The initial part of the dissection is here, and this is the aneurysm. This is the angio. This is the dissecting image. I decide to treat with atlas stent and coil, but the radial force, this is after the treatment with coiling, but 6 months later, they regrowth the aneurysm. Why? Because the stent grows to the wall of the part of the dissection. This is the 6 months later, recanalization, and look, this is the stenosis of dissection. And in this point, I decide to treat it with the cardiac stent, Pharos stent, balloon expandable stent, because have more stability in the evolution. You see in lateral view the balloon expandable stent, and this is the old stent. This is the reconstruction angio. Axial view. It is a control with Pharos. This is previous angio, this is final control. The second point I'd like to present is the dissecting aneurysm in vertebrovascular junction with rupture. This is a typical case with dissecting aneurysm have a lateral bulbar ischemia with the dissection. This is AP view, lateral view in the right vertebral. This is the left vertebral. It's possible to treat it with occluded this vertebral in this part with coil, sacrifice this part. But the problem is the spinal anterior artery is born just at the same level. This is the reason I decided to treat it with coil, stent coil. This is the stent, stenting and coil. This is the stent, left stent. Some reconstruction. Another example is dissecting aneurysm with a subarachnoidal hemorrhagia in pica. No, sorry, in vertebral. And this, I decided to treat it with sacrifice of this portion of the dissection. This is the pica. This is the spinal. It's possible to occlude this artery in this segment and occlude the aneurysm. It's best solution. Another with a stent and coils. And other group is the pica dissecting aneurysm. Pica, no in basilar, in pica. This is one case I treated with the stent and assisted balloon to liberation of the stent. This is a CT scanner in angio. The aneurysm is dissecting, is in this part, AP view. It's not only this aneurysm. The original and dissecting aneurysm is in this part. Look in the reconstruction. The origin, this is dissect, and this is a blister. Lateral reconstruction. I decide to treat it with cover with a balloon expandable stent, but to protect the moment of liberation, I place one balloon here. In working projection, you are the stent, you are the distal guide wire. When I remove the guide wire, you are many possibility to remove also the stent. This is the reason I open slowly this stent, and when the placement is perfect, I inflate the balloon, and this is the control with the before after. This is after. But before after. In another situation, it's most easy testing. It's possible to occlude the vessel because many times you have the collateral circulation. This is the reason when in this patient I treated by occlusion the aneurysm and the parent vessel pica without symptom. And finally, I'd like to present some special case which I treated with or vertebral artery occlusion or and basilar artery occlusion, sacrifice of the basilar artery in some special giant basilar aneurysm. This is the first case. It's treated by myself and Dr. Vargas in 98. Bigger middle part dissecting aneurysm. I treated at the beginning with coiling, but many more than 3 times is regrowth the aneurysm. When the aneurysm regrowth in the basilar artery, the problem is the mass effect, not only the rupture, is the mass effect. I decide to treat it 1 year later with occlusion of the basilar artery. Occlusion of the aneurysm, also the basilar artery. This is the control. The patient lives today more than 30 years later. This is the control. Second case, also treated in 89. Is the middle, is a young patient with a middle basilar aneurysm. Probably is the pathology of the wall of the artery. Is a young patient. To start, I sacrifice 1 vertebral artery, and this is the MR control. You have some reduction in the flow. Few years later, the patient don't have the posterior communicant artery and don't have open functional anastomosis of the vertebra. But I decide to treat it with occlusion of the second vertebral and finally the artery. When you have the progressive occlusion of the vessel, the thrombus of the wall not decrease, but the flow change. And I don't know why, still to open the natural anastomosis of the occipital to the vessel. And you have the possibility to have the collateral circulation. At the beginning, you don't have the collateral circulation, but finally, the patient opened the collateral circulation. This is, I close the basilar artery. And this is the control thrombus of the aneurysm and the basilar without symptom. This is another patient, but this is in distal part. I don't present because it's. And finally, this another patient is treated 40 years before with a neurosurgeon in Sevilla, Spain, a giant cavernous aneurysm by clip and ligature, surgical ligature of the carotid. This is the anterior communicant artery. But the patient have 20 years later developed an aneurysm. This is the old aneurysm treated by surgery. I decided to treat it by balloon, bilateral balloon, and I treat it here to produce the high flow in the posterior communicant artery. This is the basilar aneurysm. This is the carotid aneurysm close. This is the basilar aneurysm in this patient. This is the carotid close. This is the posterior communicant artery. This is the AP view. I decided to treat it. Occlusion of the basilar artery. Progressive decrease, the mass effect of the aneurysm. This is the control MR 15 years later. You see the thrombosis of the left carotid aneurysm, the basilar artery, and the patient is total asymptomatic. And the final case is another dissecting aneurysm on the distal part of the basilar trunk, 30-year-old. I decided to treat it with total occlusion of the aneurysm and the basilar artery with the collateral circulation. Okay, thank you. I present this particular case to open the discussion of this complex type of aneurysm. Thank you.
Thank you, Dr. Luis, for always, as always, like amazing